Please be seated. Our closing keynote will begin in 5 minutes.
Carole, what are you doing? You're
Oh, thank you, thank you.
Here we go.
Are we all set? Well, good afternoon, and thank you for joining our session today. So first of all, let me invite those of you in the outer reaches of the room to come on in and join us and make it a little bit more cozy. We recognize that this is a very large room, and it's nicer if we can all be a little bit closer together. For those of you who don't know me or haven't seen me at a prior quality conference, I am Dr. Michelle Schreiber. I'm one of the deputy directors of the Center for Clinical Standards and Quality. I'm also the director of the Quality Measures and Value-Based Incentives Group, and do a lot of work with interoperability, digital measures, and of course our value-based programs. It is my pleasure today to be hosting and moderating our session on AI for reducing burden and improving quality for providers and patients. I am joined by an incredible group of folks, and I'm just delighted that they're here with all of us today. They bring real-world experience, as you will hear from them, in how we actually operationalize some of the things that were talked about by Dr. Oz and the other panelists this morning. So it's really very exciting. Let me start with introductions, a little bit of opening comments, and then we're going to turn it to our moderators. So first of all, Dr. Jason Edelman. He is the Associate Dean for Quality and Safety and the Director of the Center for Patient Safety Science at Columbia University, part of New York Presbyterian. He has done really fundamental research in this area and developed tools regarding the use of EMRs to improve safety. So Jason, we're really glad you're here with us today. Carole Hemmelgarn is a very well-known patient advocate and a founding member of the Patients for Patient Safety US. Carole is also the program director of the Executive Master's Program for Clinical Quality and Safety at Georgetown University and the Senior Director of Education for the MedStar Institute for Quality and Safety. Dr. Alan Kachalia is the Senior Vice President for Patient Safety and Quality for the Johns Hopkins Medicine System. He was formerly the Chief Quality Officer and VP for Quality and Safety at Brigham and Women's Hospital in Boston. That was a mouthful as well. So extensive experience in quality and safety. And finally, last but not least, is Dr. Jonathan Nebaker. He is the Chief Medical Informatics Officer of the Veterans Health Administration and Professor of Medicine at the University of Utah. With the implementation of their new Oracle-based electronic medical record, Dr. Nebaker is really leading the way for using the EMR to reduce provider burden and improve care. Once again, thank you all, and thank you all for joining today. You know, as we have heard throughout this conference so far, there is great promise of technology and AI in transforming healthcare, not only to improve outcomes, but also to reduce stress and burden on the workforce, which in and of itself is a safety issue. It really feels like we're at this pivot point, this inflection point, where certainly with this administration, we think things can really start to take off. For many years, we've been implementing electronic medical records. I know I have done my fair share of that, with the great promise of better and safer care. And of course, a lot of that did happen, but the reality has not always been positive. EMRs have in many regards become unpopular with providers as they started to feel like data entry clerks. Dr. Oz spoke about that this morning, spending hours of what's been known as pajama time in doing notes or their work. And data, although it is available, is sometimes hidden still in the EMR. Patients have not always felt part of this transformation, although they certainly have benefited from many of this, but they don't always feel like they have a say in what is happening, or perhaps trust what is happening. So now that we're at the early stages of AI, which promises the ability to process huge amounts of data and quickly provide synthesis, insights, recommendations, documentation, and really a way to handle the volumes of work and data that's needed for modern healthcare. So again, today we're going to hear directly from patient experience and the leaders of those in large health systems about what they're doing to use EMRs and AI to advance quality and safe care and reduce the burden and improve the lives of providers and patients. And of course, through Carole, we will hear the very important voice of what the patients are thinking. How do patients view this transformation? What are the benefits and what are the risks? With this, each of the panelists is going to spend 5 to 7 minutes talking about what is going on in their organization and from their point of view, and we'll follow up with some questions and discussion, and the panelists, all of us know each other, are certainly welcome to dialogue amongst themselves as well. So, Jason, let's turn it over to you.
All right, well, thank you so much, Michelle, for inviting me. In 2019, I haven't written that many opinion pieces in my career, but in 2019, I wrote a piece called Building Safer Care with Just Culture and Technology. Just culture, let's stop punishing providers for being humans and making errors. And technology, because I believed the world was going to get more and more automated in healthcare, and it's through automation that we'd achieve high reliability. And then, what was it, a year and a half ago, I saw for the first time ChatGPT, and I realized, oh, this is going to change things. And suddenly, like, this modern AI major disruptor is just coming, and it's coming fast. I think yesterday I read Mark Zuckerberg is starting his superintelligence group, offering people hundreds of millions of dollars to join his group. It is coming. And I think humans make errors. I work at Columbia University, New York Presbyterian, some of the smartest people I've ever met. And they make mistakes. They make mistakes because they're humans. They make mistakes because their spouse is fighting with them or their child is sick. And at this point, a plane flying, the pilot and co-pilot can fall asleep, and the plane will just fly itself because of automation. And that's where I think we're headed. Michelle had asked me, what are we doing at our university, at New York Presbyterian and Columbia today? In the last 2 years, we evaluated 150 AI programs or solutions, most of which have been approved and are moving forward, and they range from helping radiologists evaluate and pathologists evaluate images, ultrasounds, MRIs, CAT scans, physiologic responses, fetal heart monitoring to help guide an obstetrician when you should do that C-section. Even education, creating better and better simulators to practice with like replicas of real world situations using AI. And with all that happening, I think it's like Amazon 1997. They're selling books and it takes about 10 days to get a book, meaning like it's gonna get better. This is just the very beginning and I don't even know where exactly it's headed. It's like, what company are you gonna invest in the early days of the internet boom, but it's coming. For me, as Associate Dean at Columbia, and I direct the Center for Patient Safety Science, I'm particularly focused on evaluation. I just want to make sure as it comes, it's safe. It's doing what it's intending on doing. There's been early reports already of some AI models, predictive models, not being exactly as promised, and it's because of outside researchers that we identified that. And there's also the unintended consequences. We think it's going to do one thing, but it actually is causing harm. Like the very early days of CPOE and EHRs themselves, it was a great thing. EHRs were coming, but we didn't know exactly how to do it. And some hospitals actually rolled it out and then had to roll it back because they didn't have it just right. So I'm focusing on evaluation. And then my particular area of interest as a patient safety researcher is measurement. That's how I first met Michelle. And so I'm focused on measures too. We had grand rounds at Columbia from Bob Wachter talking about AI and healthcare. And he said, right now, the world, patients don't know exactly how much to trust AI. Does the computer have to be right 99.99% of the time? If the computer's wrong, it can be very upsetting, even though humans will be right 80% of the time. But measurement is retrospective. It's a little bit safer. And I think it's remarkable what the AI can do. I'm working with David Bates, who's speaking tomorrow, about trying to measure harm in electronic medical records, replacing this manual chart review process with like large language models like ChatGPT. I'm very optimistic where the world is headed. I just think Dr. Oz on this stage said, if I run into someone from CMS, give them a suggestion. My suggestion is this major disruptor is coming and we have to evaluate it and make sure it's safe. And at the same time, there's all sorts of changing and funding happening. I think I saw an email just a few minutes ago that Senate passed the bill, now it's going to Congress. We just have to make sure there's some money and resources to evaluate this major disruptor. So thank you.
So thanks. Alan, do you want to? Carole's going to go last as the comment from the patient's perspective on the first three. So, Alan, what's going on at Hopkins?
Perfect, thank you. It's an honor to be here. Thank you for the invitation, Michelle. You know, there's been a lot of talk about AI, and there's going to continue to be a lot. And when we think about tech coming to the rescue for us in healthcare, because as Jason mentioned, there's a lot of mistakes that happen, no question about it. And I always think back to when EHRs got put in. Everybody said they were going to revolutionize healthcare and make care a lot safer. And I think most of us would readily agree that it didn't pan out the way we'd hoped, and there's a lot more room for improvement. And when I think about where we kind of went wrong in this, I think it had to do with the fact that we had the right intentions to improve safety because we put in alerts. We found a way to make sure that we didn't have to go looking for paper charts anymore, and the charts would be at the doctor's fingertips. But of course, we gave doctors a whole lot more information, or nurses a lot more information to sift through. And those two things actually made it a lot harder for the systems to work where they did. And because I think what we lost in that was the whole user interface and thinking about how do we make it easier for our clinicians to do the right thing. And again, building on what Jason said, I think there's room with AI now for there to be a lot more assistance because the computers can do a lot more today. The best examples I can think of, well, one that we're working on at Hopkins has to do with VTE prophylaxis. We all know this is something that often doesn't get done correctly, even though it's a relatively basic and straightforward step when people first come in the hospital, patients first get admitted. So we're actually partnered with Microsoft, and we're working on building a model where the computer will actually go through the patient's chart, figure out what all the risk factors are, offer them up to the clinician and say, do you agree with these risk factors? If you do, you can modify them if you want, but if you do, we will then apply the algorithm for you and then recommend the prophylaxis for you. If you talk to most clinicians, this is a step, I would argue, that actually makes it easier for our doctors and our nurses and pharmacists, or anyone who's doing it, to do their job, as opposed to before when we would just put an alert in front of someone saying, did you think of VTE prophylaxis, even if they'd already thought of it. So the idea here is to actually make the job easier. and to do it more reliably, because I actually think the computer will do a better job of going through the chart and finding all the risk factors than we often do, because it's hard to go through 10 years of charts if that's what's put in front of you. Once we work on that, the other thing that we're doing in parallel, Michelle, is something a lot of other health systems have done, which is using cameras and getting data out of your ORs, putting them up to improve efficiency. We're going to start with efficiency because the tech today can detect when you roll the patient in when the surgery starts. But eventually, I picture a lot of other things that the tech could do for us. For example, we often don't scan, a lot of health systems don't scan medicines in the OR because they need to be given quickly. But there's no reason if you pull something out, the computer can't scan it for you real time and flag an allergy or a mistake you're about to make. Or to make sure the laterality that you're doing correctly is done correctly, because the computer can actually watch and match it up with all the other records. Because I think every health system will tell you they worry about laterality in these cases because somehow it always squeaks through. And eventually, I think as we get better, we're going to go into the harder spaces, which is trying to figure out how do we help on diagnosis. We've all read the cases where sepsis becomes a problem, somebody comes back 2 or 3 times and it just gets missed. I think that's when it's going to be a little bit more complicated, because what we also want to do is not just take the data that's in the chart or the physiologic data that's available to us, but how do we get more environmental data on the patient and how he or she looks in the moment, and get information from the family at the same time? How do we put an app in their hand to get their input as to what's going on to trigger a better algorithm? But that's kind of what we're working on at Hopkins. And the last piece, I think, where tech can really help and AI can help is measurement. And Jason was alluding to this. The measurement piece has been very tricky in the quality and safety movement, because if we don't measure, we don't know how we're doing. But yet, to date, most of our measures have been limited to what we've administratively reported, or asking people to put things in a chart so we can measure them more easily. And this has had a 2-pronged problem for us. One is people don't believe in the validity of a lot of the metrics, and those of us have to admit there are a lot of weaknesses to the metrics that we put out there. And the second piece, by asking people to document in certain areas, you've actually created more work, not less work. With AI, I firmly believe that we can teach these computers to actually run through the chart and tell us we can define a measure and have the computer tell us how we did on it. And I think that is going to be the future with regard to measurement and help drive efficiency. But those are the things that we're working on at Hopkins.
So very exciting. Jonathan, the Veterans Health Administration is probably the largest organized system for healthcare in the United States. And you guys are implementing a new electronic medical record. There actually may be some folks from Oracle here in the room. What's going on at the VA?
So the first question when we think about what's going on at VA is which VA? And what some of you may not understand is variability was designed into the VA from the beginning. Well, from the late 1990s through the 2000s. So each VA was organized to innovate on quality and safety and get their practices, how they thought they were best. As a matter of fact, the old name of our EHR, the original name, was the Decentralized Hospital Computing Program. And so the world there is decentralized. So every sort of geographic collection of healthcare centers had its own EHR. And sure, they shared a common code base, but the business rules and the decision support, the forms, were all different. And we, over the last several couple of years now, and especially over the last year, have really been focused on how do we get to standardization, decreasing variability, increasing reliability, and really, very importantly, decreasing quality-associated waste. Our secretary has really made several public comments about the importance of standardization and is very interested in that. But the standardization is there for, again, reducing quality-associated waste. And so that is the variability that we need to control in order to get to more efficient outcomes, more efficient execution of our processes and better outcomes for patients, both on the safety side, reducing the bad outcomes, and improving on the quality side, the good outcomes. So so a lot of people in AI are talking about the large language models like ChatGPT and that sort of thing. I want to just highlight a little bit more of our work in more traditional machine learning and AI to deal with process mining and also process improvement. And so what we found is almost every time we look at a process, there's two types of processes that I think about. One is the operational value stream. That is how a department organizes its work or part of its work to add value to the consumer, the patient. And so I'm a geriatrician, so I still practice, half day a week and do my thing. And so I eat my own dog food, as we say in the IT business. But so one way of thinking about this is how do we process a patient through a clinic, check them in, do all the stuff, check them out. How do we take care of a referral? So from the time we think about making that referral to getting the patient the appointment. So these are operational value streams or departmental processes. So that's one type of process. The other is orthogonal to that, and that is the clinical practice guidelines. How do we treat diabetes? How do we treat heart disease? How do we do whatever, which involves all these diagnostic processes that my panel mates were talking about previously. And when we look at these processes, we do automated process design. We need ML to help with, machine learning to help with, because they're so complicated. You get these incredible spaghetti diagrams, and you would think, gee, you have an EHR. Why is the EHR process looking like a spaghetti diagram? And I'll tell you, the Oracle Health solution, and I'm sure the Epic and every other solution, probably looks the same and once we get into this, but it's just craziness, the amount of variation and regression. Most importantly, that's all waste, right? Every time there's a backwards arrow, going backwards in the process, that's waste. That also creates opportunities for decreased reliability, decreased outcomes. And so we've had success working also with partners in the Department of Energy at Oak Ridge National Labs, as well as with the Health Services Research Community, to understand both these operational value streams and the clinical process, most prominently depression management. And we're really finding some interesting things. And now we're in the process of implementing that to improve the treatment of depression, to have measurement-driven treatment of depression, to have more smooth processes for referral management. This costs us, our referral budget is now around $40 billion a year. So it's really important to get a handle on these processes to provide the best patient experience and also improve the burden on the provider to help them get their work done.
Well, this all sounds very, very exciting. Carole, what do you think from a patient's point of view? Is this really going to work? Is this what patients want? Do they trust these systems?
So I think what we have to start with is AI is like the new nervous system for patients and families when it comes to quality and safety, right? You're going to have some people that are going to jump in and use it and others that don't. So how, do we level the playing field? But I think the next thing is, and you heard Sue Sheridan bring this up today, is you're going to have more sophisticated and educated patient and family members coming in. So now that conversation truly does have to be bidirectional. So the question becomes, as we're able to self-diagnose, right? As we're able to maybe catch things real time when we're in the acute care setting and we see our loved ones are starting to decompensate, classic case of failure to rescue, are we gonna be able to help communicate this, and will providers listen? Will they actually listen because we do have knowledge now at our fingertips that we never had before? So is there going to be shared decision making? And I think that's a whole new generation of how we're going to be training physicians, nurses, allied healthcare providers, pharmacists, everyone that we interact with. And then weaving a few of the things that you've all said is when we talk about measures, are they measures that matter to patients and families? Are they measures that really look at the outcomes that we think are important? How are we treated? Did we get the treatment we expected? So many of the measures right now are process. They're not true outcomes of what matters to patients and families. And then along the diagnostic comments and what you're saying about the, the black box in the OR, how are we learning from that, right? So harm happens. Are we learning? Where does AI fit in to help us learn? And one of the other things is, how do we get upstream? So can patients and families now get more upstream in the safety and quality side so that we're doing the preventative? And that's where I think AI will really help in that aspect too. So it's about knowledge, but on the converse side, Michelle, it's the trust. One, you're gonna have patients and families that don't know enough about it. And the fact is, we know there's studies out there. One of my colleagues, Raj Wadhwani, has been doing these, said, I can go to ChatGPT and say, you know, if I'm on penicillin, should I take amoxicillin? And I get one response. And I can go to Claude and I can ask the same thing and I get a different output. And I can go over here to Gemini. Patients and families may follow one thing and now mixed messages are there. So there's a lot of benefits. AI is here to stay. I think there's beneficial things, but how do we level patients and families up to know what's good input and what may be good or bad outputs?
So very important insights. You know, with all of these new technologies, it seems that both staff and frankly patients have to acquire some new skills so that they can become very familiar with working in this. I know, having implemented many EMRs, that we had providers rebel and frankly leave because they felt like they couldn't catch up with the technology. What do we do to upscale and train our staff and frankly to even be teaching patients? So what are we doing for our staff so that they understand this and they're ready for this new world? And any of you are free to comment, but Jason, you sit closest to me. So.
Yeah, it's a great question. And I think a lot of what's been going on at Columbia Neuropresbyterian the last 12 to 18 months is preparing for that question. We've had so many, in the universe that I live in, there's the hospital, Neuropresbyterian, there's Columbia University Medical Center and the medical school, there's even downtown Columbia, and then there's Cornell. There's lots of people that want to be in this space of AI and healthcare, and we need rules of the road, just how to work together and collaborate. What AI models can we try? How do we educate our staff and our patients? How do we check it to make sure it's safe? Safe for, not just safe for our patients, but also safe from data breaches. And there's recently I've noticed, like within the last month, education modules online to teach staff. There's the ChatGPT that's in the public domain, and if you type something in it, it's in the universe. And then there's the secure one, and clinicians on the floors can use the wrong one and type in a patient-specific question, thinking they're in one but not the other, the secure versus the not secure. So like it's fast and furious, this education and regulations and guidelines all coming at us to just sort out this new world. This disruptor is coming very fast. I don't have a great answer, except I know that people are spending a lot of time thinking about it and planning for it.
So at VA, we have about 2,000 self-identified informatics workers. And so these are the people that, you know, keep the computer systems running. They do the manual updates. Remember, we have about 130, well, now with Oracle, we have 124 separate EHR systems that are administrated by this 2,000 strong workforce. The workforce was trained to be CPRS and VISTA technicians. So they know which buttons to push. They know how to write the little, you know, some of the little code to get the EHR systems to work. But in the new world, especially with Oracle as a partner, we won't be doing a lot of that, especially at the facility level. We'll have a more centralized, I'm sure, you know, all you guys, I know you do, have your centralized EHRs. But what we've been doing, and I see, you know, some friends here who also been working with on some educational programs, and including with the American Medical Informatics Association, is developing curricula to retool the workforce to be able to move from being a technology, you know, dial adjuster and code writer to really helping to be a kind of a change agent, and also be able to, so now they'll have the skills to understand how these technologies are working and be able to help the clinicians and the patients in some cases use these new technologies. So, you know, Jason was talking about some of the regulatory and Carolyn about, how do we manage these, different recommendations that are coming in. What we envision is helping that, building up a super user workforce, not only with the 2,000 strong informatics staff, but also with super users drawn from various services, so they also understand these issues. And so again, we're working on the curricula. We're going to be open sourcing our curricula. It already is, public domain because it was made by, VA staff, and we'll be, also partnering with other institutions, and hopefully we can, with some nonprofit, professional agencies, try to make this more available to more people.
Go ahead. I hear this, and the question I was asked is, we design everything in silos, and we do not co-design, right? So where are the patients and families in this design process? If we're saying we're creating curriculum for our staff, are the staff not talking to the patients and families? So it's like, we gotta think of co-designing, because if we keep doing healthcare in segments and silos, we're not fixing one of our biggest problems, and that is the communication aspect of it.
So I agree with everything I've heard. The other thing I would add to this, Michelle, is thinking about training or making sure the people who run these systems are thinking about key pieces. So one is, how do we store the data? How do we make sure that the patients and the staff know how have consented, if you do ambient intelligence, that they've consented to their images? How do we make sure they know how this data is going to be used? Because if people think it's going to be used for just big brother purposes, there's going to be a huge adoption problem as well too, and a trust problem. Of course, especially if you store images, how do you think about the data security piece, especially in this day and age from things leaking? And of course, making sure these models work. How do we make sure that we're studying them correct? And do they need to be open so that people can make sure that we don't have unintentional biases that are leaking into what we do? So those are the other things that we need to make sure that people who run these things or implement these things, they're thinking about these bigger issues as well, because not only could they impede implementation, they could actually cause more harm if not done correctly. And that's actually harder for us to get done, than that. I worry more about that than I worry about the tech itself.
So speaking of which, Carole, what's your take? Do patients trust this yet? And what will it take to build trust?
I think that's a hard question. I think some do. There's definitely reticence. And if you think, the 21st Century Cure Act finally gave patients the ability to access their information, their data, portals. So I think they're coming along. I think what'll set us back is if there's negative experiences, and all you have to have is a couple negative, and then they start talking, and then the trust is gone. So the important thing is making sure that they're safe and that patients and families actually know how to use them in a beneficial way. But trust is going to be a huge, huge issue. And again, I think one thing goes awry, I think it can take us downstream.
I'm going to switch topics just a little bit. So we deal with measures at CMS obviously all the time. We get data all of the time. And one of the key challenges, I think, is that, frankly, the data is not always clean, to be really honest with you. And we have these AI tools now that are going to sit on top of data that comes in and isn't necessarily clean, and it's going to make decisions about data that's not necessarily good. How do we address that? What are we doing to fix this or to make sure that we are basing our decisions on fundamentally correct information?
So I'll bite on that. And so I have a little public service announcement to go along with it that we've been working on with HHS. And so there's kind of two problems, and most people in the audience may be more familiar with the kind of the methodological issues here. But there's two problems that we have. One is, how do we categorize various types of data, put them in a schema so the AI can understand? And so let me just give you an example. So when we first started working with Oak Ridge National Labs and their cybernetics group, so these are guys who manage the nation's power grid, right? So they understand threats and they understand all this kind of stuff. And we said, okay, let's try some experiments working in critical care, actually, which was probably a really bad place to start. And they said, so they went off and they did their thing, and we gave them a little bit of consulting help. And they came back and they were so proud of these graphs that you just couldn't make any sense of, right? And so it's like reading tea leaves at the bottom of your, of your teacup to see kind of where it's like, oh, well, maybe this means, that, the lactated ringers is better than normal saline. And, it was just incredible because the data inputs were a mess. So one is, it'd be great, and there's been some work on this to get standard data schema. In the FHIR community, there's been a lot of work on this, but for reliable data input, so software as a service, other people's software can use the data in a predictable and, to not create not only hallucinations, but just kind of weird stuff that comes out of it. The second is something that we're trying to get to with the Picky framework. So if you look at pickyframework.org, we're trying to, it's a coalition working with all sorts of public-private partnerships, currently hosted by Levitt Partners, and where we're trying to get at the basic data quality. So internal to an institution, most institutions can handle their data pretty well to get the right data going to where it needs to be. But once it starts going out of the institutions, for some reason, there's like bad sprites in the EHR where we're dumping a lot of weird data, and we have a lot of missing data, low quality data. So all these FHIR-based exchanges, or even non-FHIR-based exchanges, the data is just not computable in a way that we can measure quality, let alone provide decision support. So we gotta really get that first level of data. And so again, I'd refer you to pickyframework.org. It's a, nonprofit. It's even more than nonprofit. Like free and donated work, large collaboration with HHS, VA, and all sorts of different partners, including NCQA, et cetera.
Any other thoughts?
I'm not a data scientist, so I'm not sure about the part of your question about how clean the data is and the complexities of the underlying structure, but at the heart of your question was, how do we make sure that the measures are valid and useful? And back when we were looking at measures together, I thought the criteria we used then are still applicable today. Just robust evaluation, is the measure valid? Like, is it representing what it says it's representing? And go and check, do rigorous evaluation. Is it reliable? If you evaluate it at one organization, go evaluate it at many other types of organizations and make sure it's still working and it's not just a New York measure or a Texas measure or a large academic medical center. Is it something impactful? Pull in the patients and the stakeholders and the providers. Like, is this something meaningful? Is there still an opportunity for improvement? Like, if we're going to measure this, let's measure it. As Alan said before, we can't fix something unless we can measure it, but first let's make sure it's a problem we care about and there's room for improvement. And I think if we just keep following the criteria for the ECQMs today and CMS measures, apply them to the hopefully many new measures that will come from AI technology, we'll be in good shape.
So I have two last questions. The first is, and this may have happened to some of you and it's happened to me, went in for a mammogram and they said, hey, for $60 extra, you can have an AI reading. Should we be charging extra for this? Because I tell you, if you don't pay for it, you kind of feel like you're not getting the best care. So what's your take? Is there anything that you guys have seen in your organizations about this?
Look, the VA, man, your service connected is free. If you're not, it's $8. That's all.
Yeah, I don't think we should. Do I think it'll be woven in and patients won't know? Yeah, I do. Again, this technology, everything is moving so quickly. Are we paying for something we're not sure is actually accurate? Where is that trust in it? But do I think eventually it'll be a cost and it'll be on the list of everything there? Probably. I'm just not sure patients and families will be aware that they're actually paying for it.
I think this will evolve and we will see. So my final question, we have a few minutes left. Is AI and technology going to replace all of us? Is care going to be through avatars that you do this on telemedicine through an avatar. What do you think? Are we going to be replaced?
I think it's impossible to know, of course. I think remarkable things are about to happen, and we're going to test. You know, AI can speak to us with empathy, but will it replace like a human in front of another human? I don't know. And it might be like a genetic counselor, where behind a genetic counselor is incredible technology, breaking a gene up into its parts, finding information and learning about potential risk. But then a genetic counselor takes this complicated information and explains it to the patient. So maybe I can envision in the not so distant future where somebody does a research study like a physician assistant and AI versus a doctor, where the AI is giving a lot of the intelligence and differential diagnosis, and the PA is putting on the stethoscope and communicating. And what that would do to the financial model of healthcare, and if they'll be charging $60 for that AI, I don't know. And so it's hard to exactly know how good the empathy will be from computers. And I imagine it'll be some hybrid of things, but more reliability is coming.
So you guys are the quality experts, right? And I tell you, I'm not a quality expert. But what I'm trying to get, I'm trying to popularize in the internal of the VA this concept of what we want, what we care about, what's quality. So one is the patient's service experience, that like, can I get parking? Is it convenient? Can I get my thing on time, my appointment on time? The second is their healthcare related experience. That's like not their hemoglobin A1C or their blood pressure, but you know, can they walk up the stairs without getting short of breath? But there's a third concept that I learned from Brent James, and you know, several executives in our organization have endorsed it sort of independently, is the therapeutic relationship. And Carolyn was talking a little bit about that. But it's, again, the therapeutic relationship as a kind of a separate sort of experience that the patient has. And I think, you know, that resonates with people who've been in healthcare, or that either on the provider side or the patient side. I don't know if the computer is going to be able to do that. We know Chris Johnson's study, you know, from a couple of years ago, where they had just longer responses that the AI generated were better than the short responses that the physicians gave, you know, on the messaging. But longer responses is not the same as a therapeutic relationship, right? And so I agree with Jason. We're going to kind of see where this is going to go, but there's a little. I still think there's going to be something special about humans. Maybe not, but that's my thought.
I'll just add quickly, I think we should welcome as much as AI can do for us if it can do it right. That's the key piece here. Because when we think about automation in factories, they've taken a lot of mundane tasks off our hands. Jason mentioned the planes being able to fly themselves. There's nothing wrong with that. You still need people to run these things. You still need people to drive the new knowledge and the human interaction, as you mentioned. So to me, I see it right now as a world where it should make our lives a lot more efficient and easier and safer. And it remains to be seen whether or not we'll be replaced, but we'll see.
I think that there's a role for both. So if we have the, my Oz analogy, not Dr. Oz, but Wizard of Oz, you know, you have the mighty and powerful Oz, which is AI. There's great things, but behind the curtain is still the human. We cannot take humans out of healthcare. There still needs to be that connection. You know, we need that. That is part of our inner core and being. So it's how, as you were saying, Jason, how do you use the strengths of both? That this technology might help providers, but the providers are still there having the conversation and the delivery. And all of us that are parents that have had kids, I can't imagine, you know, not having that pediatrician there. Or, you know, when you have a horrible cancer diagnosis and everything you're going through, we still need that human connection.
I certainly hope we always keep the human connection. Number one, I don't think all of us want to be put out of business. Number two, I think there is something intangible, really, about having that human connection. I mean, there are even multiple studies that social isolation is something that is not a good thing. You know, people actually can experience harm from social isolation. And sometimes I worry about if you're just going to connect with a computer, where does that come in? Where does that personal relationship actually come in that we think is actually the true heart of medicine and healthcare? And that, I think, is something that we always have to preserve. But there's going to be so much exciting help, I think, through AI and technology. I will tell you at CMS, we've talked about ChatGPT. CMS actually has its own GPT, CMS Chat, actually, and so we are starting to use AI even for policy or looking through procedures. And I tell you, there's something nice about AI being able to read 2,000 pages of the Federal Register and summarize it for us. So we are looking forward to these tools too. I want to thank every one of our panelists. You guys bring real world experience. And Carole, the voice of the patient is always what we need. Looking at all three of you to make sure you have patients incorporated in the work that you're doing, just what Carole said, co-developing with patients. And I look to all of you in the audience to be sure that we are always co-developing with patients. It's essential to what we do. And I thank you so much for your participation today. Enjoy the rest of the CMS conference. Thank you. Why don't you lead? Okay, we have a short 15-minute break. The sessions then will continue in the various rooms after that time.